Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dell Simons Family Studio. Delighted to be back with you on this crisp but wonderful Friday morning here in May. What a gorgeous day it is. We are joined in our studio this morning, of course, by the ever-faithful Doc Hawk, who is back with us, the Medical Director of Infection Prevention Control. And we're also joined today by Lance Williamson, the Infection Prevention and Control Nurse Supervisor. Together, we're going to be answering all your questions that we can hear or we can think of around COVID-19. But first, Hawkeye, I may be happy this morning, but the numbers don't make me happier.
Yeah, you know, I think in the United States, with number of new cases, I think we can be optimistic.
Yeah.
I think in the Kansas City area and our metro area, you know, we've seen some slight increases.
We have.
Some trends increasing daily cases and 7-day rolling average. Here at the health system, though, this past week really hasn't been good. It has been an uptrend for sure. We're up to 24 active infections, almost half of those in the ICU, 11 in the ICU, with 9 on the ventilator, so a large proportion of
those. That's a bad number. That's a bigger ICU number than we have seen for a while, and I don't like the 9 on the ventilator thing.
Yeah, and still 9 in that recovery period, so 33 total patients. Hays has 2 active patients as well. But again, I think for our trend here at our hospital, you know, it's concerning.
And guys, these ventilator patients that are up there right now, they're a little younger than they were before, because I don't think we have quite as many nursing home people here.
Yeah, I mean, I think the story that we have been telling is who are we not seeing here in the hospital, and it is that 70-plus nursing home age group who has been vaccinated, so that is a good thing. But we are still getting older patients in. Again, as of the middle of the week, we had only 1 patient that had been fully vaccinated that was in the hospital. That patient was not in the ICU, but was.
Yeah, and that's something I think we should expect when we vaccinate high populations of older individuals, is that the virus will find younger bodies to infect.
Yeah, I think that's right, and I think that what we're seeing is all these non-vaccinated patients who are coming in and going on a ventilator. So once again, the answer is V for vaccine, live long and prosper.
You know, and we're continuing to get more and more real-world data now out of such as Qatar and Israel and even the United States in our healthcare workers when they're looking at the endpoints of really either symptomatic disease or just asymptomatic disease. So not just hospitalization, severe disease, and death, but looking at any infections whatsoever. And it's really, you know, we're getting to the point of really proving now that the vaccines really protect you from any sort of disease, whether it's asymptomatic or even mildly symptomatic disease, with great efficacy.
They really do. Some interesting data has come out in the last couple of days, just to say. First of all, Novavax had a trial down in South Africa. What do you think? 49-50% vaccine efficacy against the 451 variant.
I think it was really encouraging, and that is one of the vaccines that I would like to have brought to market because of, again, we have used other vaccines in the past that are protein vaccines just like this, a little bit different mechanism, but really the same protein or subunit vaccine. You know, the safety profile is there. The efficacy really looks there as well, and I think they were looking at symptomatic disease as well.
They were. So they did actually pretty well with that, and it's encouraging because it shows efficacy against the B451. Second thing that's come out this week, Moderna has said they're ready to go with the booster if necessary, and they've reformulated the booster, and the booster looks really effective against 451. Yeah,
I think we're hoping that there will be the booster, and I would certainly be really excited to get that booster with the 351. And moving forward, again, I hope that they're able to incorporate more modified RNAs to create more of those variant of concern spikes so that we get immunity to that. But I think the most important thing there is even the regular wild type vaccination that you're using has shown to still have good efficacy of cross-reactive protection against even that South African 351 variant.
So I think we're looking really good around the vaccine news. Again, also showing an amazing safety profile. In fact, the safety profile is so good that Pfizer's decided that they're going to apply to the FDA for full authorization next week, and Moderna says they'll be doing it this month as well. So if if we have a fully vaccinated or fully authorized vaccine, that demonstrates complete safety and efficacy in that situation.
Yeah, and then I think we really need to start having further conversations about what entities can then mandate. Again, we know that entities such as healthcare entities mandate certain things like hepatitis A and B vaccine because we know that they're safe. We know how much it protects against those diseases. We make sure you have your measles, mumps, and rubella immunity, that you've had those vaccinations. Influenza vaccine, because we know those things keep you safe, keep our healthcare workers safe, keep them coming to work and not home ill.
Yeah, it does make a huge difference, and I'm looking so forward because, Lance, we have really good uptake with our influenza vaccine here in our health system. We have 15,000 people, and I think I heard the other day we only have 33 people who didn't get the influenza vaccine, and we require the vaccine. Only 33 actually ended up not getting it.
Yeah, that's what we see in healthcare. I think we all realize how important it is to use that vaccine to ensure that when we're taking care of our patients who have little to no immune system, it's so important for us to do that. So I think we realize that in our setting, and hopefully we can translate that with the coronavirus vaccine in our communities as well.
I think that's right. And as we put on our long-term hat here, once we have fully authorized vaccines, I think the health system will probably require that, and hopefully we'll see that same kind of uptake. I think it's going to be a pivot point for us to think about, are we going to require it in different venues, especially if you want to go back indoors, say to Allen Fieldhouse or the Sprint Arena with fully packed audiences or anywhere else, because at that point, you really, I mean, the infection dynamics are pretty significant, right? Because you got a lot of people tightly packed, all breathing hard and cheering, or at least we're cheering a lot. And so I think you really need to think about, gosh, we're going to have vaccinated crowds in situations like that if we want to prevent disease transmission.
Yeah, and it's a good way to promote the vaccine when I think it was the draft that it was clear that they had a signage that was, this is all vaccinated people that were in this area unmasked, kind of promoting that use. So I think we have to balance that, the promoting of the vaccine and showing like there is some sense of normalcy when you do get vaccinated, and making sure that we're doing it appropriately for all of our population as well. Yeah,
really important. So some really big news this week on the vaccine front, and I think countries like India are saying, gosh, give us more of that vaccine.
Yeah, I mean, they would do anything to get their hands on it.
Well, it looks like they may be headed back toward lockdown again, and I think that should be a warning to us all, that if you're not really well vaccinated and you have numbers starting to rise, then you're going to be forced at some point to rethink about lockdown. Japan did go back into lockdown in Tokyo and Osaka because of trying to prevent further spread prior to the Olympics.
And I think if you want to talk about, the benefits of the vaccine for you individually, for your bubble, for your loved ones, but also for broader things like the economy. We know now, we have seen these stories about shortages. There's going to be a gas shortage this year because there's not enough drivers who are trained because they were all ill, they stopped work. We know that there's a large increase in the price of wood because Canada was shut down because they didn't have the workers and the drivers to get that wood and deliver. Same thing with steel as well. So this is a big driver of the economy as well. And doing that and keeping our workers healthy, those able-bodied workers from 20 to 65, keeping them healthy and from having to miss work is very important. So that is one other good aspect of global vaccination as well.
So important. Well, one other thing we wanted to point out this week is because we are always at the height of science fiction, fantasy, fashion. Let me say that again. Science fiction, fantasy, fashion. We celebrated with May the 4th be with you, but today, as a true Trekkie, I have to come back with my Star Trek ties, and I just want to point out how good they look. Right. And yes, that is the USS Enterprise on the front of my tie. And yes, we are here on the Morning Media program at the height of science fiction, fantasy, fashion. Say that fast 4 or 5 times. Let's see how you do. All right, Bob, let's see what questions are out there from our audience today.
Well, first, let's see if we have any reporter questions on the line.
I'm not in the chair for a couple of days. I forget to talk to the reporters.
Keeping you honest.
Please do. I'm not hearing any, Bob.
All right.
Let's do it.
Okay, we have a few coming in just this morning, and then we'll get to the ones that have been left over from the rest of the week.
Yes, sir.
First off, Ann wants to know, what are your thoughts on people not masking at Royals games?
Yeah.
Well, okay, A, if you're outside, it is safer than if you're inside. B, if you have distance and you're inside your pod, it looks pretty good. I'm going to say that sometimes a little nervous now, the shot's right behind home plate, where people are more packed in the crown seats and they're not wearing masks. But again, if you're in your pod, I think it's okay. It's when you start getting a little bit more packed in and you don't know everybody, even outside, you can spread a little, Lance.
Yeah, and the CDC updated guidance that said if you're fully vaccinated, you can take off the mask while you're outside. I think we know outside is a safer environment, so I think it's generally okay. It's just that kind of coming together because transmission can occur outside. It's not impossible, of course. So I think keeping that in mind is
being fully vaccinated makes. I'm actually ready. I'm going to go back to a Royals game as soon as I get so the timing's right, and just got to get the ticket spot and go. And I'm pretty comfortable, to be honest, because I am vaccinated. I don't mind sitting in a little more vacant area at that point. What do you think?
Yeah, I think if we can get a more proportion of people vaccinated, it's definitely better. But we know outdoors is safer, and that's kind of the verbiage as well that the CDC uses. We know that there are more safe and less safe situations, and certainly being outside is more safe. If you can still separate in those seats, if they aren't in your pod or with people I think that's important. But outdoors has shown, because of lack of super spreader events, essentially, or lack of identified super spreader events, to be much more safe than doing something.
We even know the marches last summer did not spread virus.
So,
those are pretty good.
Oh, they were actually really pretty good about masking.
They were really good about masking. Maybe not the Lake of the Ozarks shots we saw. No.
But I think we didn't identify really a necessarily unique cluster of super spreading event there, even though they were pretty much on top of each other, close proximity to each other.
Yeah, outside is a difference maker.
All right, Megan says, good morning. As a fan and follower from Johnson County, I don't feel comfortable going past these phases of CDC rules and regulations. How can I feel comfortable with not opening fully in my own business as a hairstylist? I prefer the social distancing with better rules than I have now in my workplace.
The evidence around and I'm not sure if this is completely in step with the question, if you're masked as a stylist and your customer is masked, there's really very little risk of transmission. And I would say if you're both vaccinated, there's very little risk of transmission, or at least a much lower risk of transmission. But staying fully masked is probably the way, if you want to be 100% safe. That's what the data would say.
Yeah, and I think in that situation, when you're actively working with a client, definitely mask both of you. That will be the safest. We still do that in the physician's offices, even though our exams don't take as long as it does to do hair. We're masked. A lot of our patients are masked. There's very few that's not in the outpatient clinic setting. So I think it's important to do that. But you also have some data to back that up, just like you said. Some of those original articles and that investigation from Springfield with the hairstylist was very encouraging as well. But you yourself can get vaccinated. Please encourage your clients to get vaccinated.
And to Doc Hawk's point, Lance, we're still requiring our staff to be vaccinated on all of our units, all of the floors. I'm not vaccinated, sorry, to wear a mask on all the units, and we're asking the patients to wear masks as well.
Yeah, and I think that's what we have to remember here is that even when governmental restrictions are lifted, we're going to have kind of incremental step-by-step changes in wherever you're at. So you may go into, and I think this person has agency to, if you want to keep a certain capacity in your area, you can manage that and really try to ensure that your customers are following that as well as part of how you want to function your business. If you want to keep the masks on, you can definitely recommend that, even though, wherever you're at, you may have a different guideline with your governmental restrictions. So I think that's important. And healthcare has always been that way, where CDC will make recommendations, guidelines for the general community, and then our job is to interpret that for our population, our staff, and then our patients as well.
Yeah, I think that's a really good point, and all of us have our own agency to make this decision about what's safest. And what we can say to this person who's a stylist is clearly having you wear a mask and having your customer wear a mask is the safest thing. Now, the public and the county health departments have a lot of different pressures on them, right? They have economic pressures, they have political pressures, they have healthcare pressures, and they may say, look, we think we're at a point where it's safe enough to go ahead and stop the masking mandate and returning things to be full capacity. That doesn't mean that you have to. Because that choice is not necessarily the safest choice. It may be the best choice for the county because that they're asking and answering a different set of questions than that individual hairstylist is. If that hairstylist says, gosh, I'm a little nervous and maybe I have some health concerns or whatever, you have all the right in the world to say, I need to wear a mask and my customers need to wear a mask, because that really is the safest single thing you can do. If you really want to prevent disease transmission, reduce risk to you and to the people who you love and care about, then that's what you do. But again, that's a different set of questions than what the county's trying to answer. And the numbers are lower. We are better than we were, back in the end of November and December. And so trying to make some individual changes, I think your point is just dead on, Lance, that you do have the individual agency to make that choice.
Yeah. Because the mandates are gone, the virus is not.
Yeah, the virus is not gone. Funny thing how that works. The county has a lot of questions there. They got all this. They can say all this stuff, but they have not made the virus disappear yet.
Right.
That would be an awesome trick.
Okay. Earlier you mentioned the Novavax vaccine. It's having some new data coming out. And Isaac wants to know, how is 50% vaccine efficacy encouraging? Seems pretty bad to me.
Yeah. We're so spoiled by Pfizer and Moderna, 95% efficacy. And that's an amazing results. But if you go back to the last summer, and we were worried, what kind of vaccine efficacy we're going to see, we said, gosh, if you have 50%, which is often what influenza is, you'd say, hey, that's pretty darn good. We'll take it. It's just Pfizer and Moderna came in at 95% efficacy and are pretty darn efficacious. I think it's around 70 to 80% efficacious against the B451 variant. So, and I think the key in this situation, Hawk, though, is that not only did it reduce disease, but it really reduced a lot of severe illness.
Yeah, and I think their endpoint for this, as opposed to some of the other ones, and I have to go back because it's been so many now, their endpoint was looking at symptomatic disease.
Yes, it was symptomatic. I was just looking at that study a few minutes ago.
So a little bit different endpoint, but I still think it's encouraging, and I would be happy to get that or give that to my children if it were available. But I'm going to get them the first available vaccine.
Yeah, and I think, and again, fortunately, we're blessed to have the Pfizer and Moderna vaccines here in the United States, and those, and the J&J vaccine, which also showed pretty good efficacy in South African variant. But we're pretty blessed around those things.
Gene is wanting to know, can you mix a Moderna booster with a Pfizer original vaccine?
Great question. It's something I think people are trying to take a look at.
Yeah, I thought I just saw something.
I thought it was going to be okay. I thought.
Yeah, I think overall, inherently, in the big picture, yes, it's okay. Right now, there's just lack of data. And again, as we move further into this, with more vaccines available, new generations of vaccines, we have to believe that in the general population, in the general public, there probably is going to be some sort of mixing. But overall, inherently, yeah, I believe it's safe. It's not encouraged right now. It can be done in extenuating circumstances, but those are questions that are being investigated scientifically.
All right, last question from this morning, and then we'll get to the ones that were left over. But Isaac is saying, I know several colleges will be requiring vaccines for students this fall. What are your thoughts, and do you think KU will be doing so?
Yeah, I think the KU question we're going to leave to KU. Maybe we get a chance to have Gerard back on here and we can talk with him a little bit about it. So what are you thinking about? Here's my stance around it. While they're under early use authorization, I understand the hesitancy against mandatory vaccination because they're not fully authorized, but they are being offered. Once they are fully authorized, I don't have much hesitation about saying, you're going to have a mandatory vaccine. We're going to have it in healthcare, and many hospitals have already moved that direction. So I'm not going to stumble once it's fully authorized, because COVID-19 is a real crisis and it's not a hoax.
Yeah, in my opinion, I would be supportive of that for several reasons. We know that other vaccines are made mandatory. Things like meningococcal vaccine, which is extremely deadly, probably much more deadly to that population than COVID is to the young population at college, but nonetheless, it can still cause significant outbreaks or problems, for instance, in a dorm. We know that also if you want to participate in things in college, and a lot of young people are participating in things, whether it's athletics or the performing arts, band and orchestra, things of that nature, we know that it's going to be important to have vaccinated people, so you individually are not missing participation days by being ill and out or quarantined or anything like that. So, in my opinion, I'm okay with that for those reasons there, but also protection of the other adults on that campus, your professors and things of that nature, so that you can continue to do that, continue to go to classes, and again, get back one more step to how things were in 2019 rather than what they were in 2020.
Lance, what are some of the other mandatory vaccines we require here in the health system besides influenza?
So we require flu. There are hospitals that require MMR, things like that, and sometimes in special units like populations, like a BMT population or severely immunocompromised. Right now, the only thing that's required for us is flu, but I know that there's a push to add things like MMR, things like that would help us reduce that, unintentional transmission in these cases, because that does happen. We see measles outbreaks. That was kind of a big topic before the pandemic, right? That was happening a lot more. So flu is kind of the main one that's the most popular, but if you ask someone like me, I'm always going to be promoting the more use of the vaccines, and I think we all know it's so clear to us that these are so extremely safe vaccines that we would want to mandate them whenever it's possible.
Yeah. And I think on your topic of MMR and measles, we know that when measles was occurring here in the United States, a lot of those cases were from foreign people in the United States, because not all of the countries have as good vaccination program, especially against measles. So then you get into the lack of herd or population immunity in those countries. But when it was brought here, although there were more cases than normal, it never became a huge problem or an outbreak or an epidemic in any one local geographic region.
Yeah.
All right, let's get to some of the questions we didn't have time for earlier this week. Atchison Emergency Management texted out that the P1 variant had been detected in Atchison County. What concerns are there with this compared to the UK variant?
First of all, what's the P1 variant, Hawkeye? Let's remind our audience.
So P1 variant, so we have to remember in a broad stroke that all of these variants variants of concern that we know about, they're all associated with more than one mutation or substitution or change. It's not just one thing. The P1 variant was first identified in Brazil. It has a substitution or a mutation similar to the UK, but it also has a mutation or substitution in the spike protein. We're talking about the spike protein similar to the South African variant, B1351, and that's the 484 amino acid substitution in the spike. So that's what all of these variants are, is certain mutations, certain substitutions, mostly within the spike protein, that allow it to either not be treated as well with, say, monoclonal antibodies, maybe evade the immune system a little bit better than the original Wuhan strain to what these vaccines were made with. That is why these are concerning. How concerning is the P1 variant to the UK variant? I would say not right now. We know that a large proportion, depending on what variant site you're looking at or data set you're looking at versus private companies and the CDC and the state, the UK variant in Kansas probably consists of 65 to 70% or more of the total proportion of variants identified. I believe the next one is the California variant. And there's very few and a lower percentage of variants P1 within Kansas. I think it's like 1.5%. So right now it's not as concerning. It's not as concerning as the South African variant. But the reasons for concern is the South African variant itself, because of that 484 substitution, the same thing that the P1 variant, the Brazil variant, has, does seem to evade the immune system a little bit better, and there's less efficacy to the vaccines. But that is why it's all the more important to get vaccinated, because we know your immune response to the vaccine causes better or greater immune protection against the P1 variant, against the South African variant, than does, say, a previous natural infection.
And we know, based on some of the information we've heard from Dr. Norman, that over half, or at least half of the vaccine of the infections in Kansas now are no longer the wild type. They are a variant, and the majority of those have been the British variant.
Yeah.
But there have been some South African and now the P1 variant. And so I think it's not a surprise to us that these are occurring. They're going to occur. That's how these things are transmitted.
And just looking at and again, the most updated data is from a few weeks ago in the state of Kansas. It does look like the UK variant is probably, for instance, in Wyandotte County, all of the isolates they tested were the UK variant. In Johnson County, it was about 65 or 70% of the isolates. In Sedgwick County, it was about 70% of the isolates. So again, they're not testing every isolate. They're doing sampling, but the UK is certainly more concerning. Right now in Kansas, the P1 looks to be less concerning, probably about 1.5% of the total isolates.
Does it look like boosters will be just one shot or two?
I think it's going to be one shot right now. I'm probably around it a year at a time, but there's been some talk of the 6-month booster, Hawkeye. And the Moderna has just, as we talked about earlier in the program, has just pushed some evidence out suggesting that either the base wild type, if you will, booster is also very efficacious because you get that extra boost of your immune system against the South African variant. But the new formulation they have is even more effective.
Yeah, I mean, I think overall, most people are anticipating a booster or other shots, if you will, at least around that 12-month range, probably not really before that unless it's needed based on any certain circulating variant. We know the vaccine companies, particularly Moderna, Pfizer, with their mRNA vaccines, can pivot quickly, but I think before a year, that's really a quick pivot. I don't know that they'd be able to do that.
Unless we just had to because of the variant. It just doesn't feel like there was any evidence for that so far, not really. Yeah. The other thing to say is Moderna is also looking at the mixing of their vaccines. So you have even, you'll have a mix of the messenger RNA programming in there to be both the wild type and the South African variant, the 351.
Can a vaccinated person give the virus to another vaccinated person? What are the risks, if any?
Lance, we know that you can still spread it even if you've had the vaccine.
Yeah, I think that what we're learning with emerging data is that it's unlikely. It's not impossible. I think anything we're not going to really talk in absolutes in most of the things that we say here. So I think it's important to know that it's really unlikely that an unvaccinated person will get the virus and then transmit it to someone who is also unlikely to get the virus, another vaccinated person, which is why the CDC is saying if two people are vaccinated, they can hang out inside without masks on. So I think that aligns with what we're seeing with the new data too. So it's encouraging, and that would be unlikely, that situation.
Yeah. I mean, I think overall, it's the data would suggest it's less and less likely, significantly less likely. But again, these are also experiments looking at the wild type, or the main circulating strain at the time, especially when the vaccines were made. Also looking at the 117 now. We know you get better efficacy against the 117 variant as compared to the Brazilian variant, the 351, with these vaccines. But what if that Brazilian 351 variant becomes more prevalent? Then that'd be concerning. And that's one reason why I am looking forward to maybe a booster with that mRNA vaccine against specifically the 351 variant. But overall, to answer that question, it looks like it's less and less likely, significantly less likely, but it's still not impossible. And that's why right now, as the CDC takes guidance, it is baby steps to allow vaccinated people to do things. It's not just a free-for-all going out without your mask.
Yeah, fully vaccinated people should be concerned about the variants because, and I think the takeaway, we get a lot of questions about the variants. I think the takeaway for the community is to understand that anytime the virus replicates, that's a chance for mutations, and then subsequently these variants that we see, they can come up with that. So preventing additional infections is how you prevent new variants from coming about.
Yeah, and I think it's also important to remember that the vaccines also help protect against severe disease. And so that's another reason to have a vaccine. It does reduce transmission because it also helps reduce replication. And it's in the replication, when a virus divides, that they begin to have those mutations to their DNA, which allows them to mutate, and that's how the variants develop. So vaccination is important for a lot of reasons. First, it can decrease your own risk of severe infection. Second, it can decrease your ability to transmit the virus. And third, it reduces the risk of having mutations occur. All of these are good reasons to protect yourself and the people you care about and society as a whole. This question about, vaccines are causing disease. Gosh, people, we just got to get off that. That is just wrong. So stop that. Realize the science is real. And what you need to do is quit listening to the politicians and those people who really don't know very much and listen to the science. And the science is overwhelming about vaccination. whether it's the polio vaccine, the MMR, the influenza vaccine, or yes, the COVID-19 vaccination, vaccinations work.
How many deaths have you seen in the past few weeks? With the numbers going down, I'm wondering how many people are recovering or dying from COVID.
Yeah, that's a great question, Lance. What are we talking about here at the health system?
Yeah, I mean, I think that we have seen the reflection of what the United States has seen overall with the decrease in hospitalizations and deaths overall. So we have seen that. We report that out every day, looking at those, and it has been reduced, especially since that peak that we saw in November, December. So
yeah, it's true. Better. And it's been a while since we've had our last death.
Yeah, we had our last death. It looks like last inpatient death was 5/4.
Okay.
So we got this today. But overall, I think we've seen less deaths in general in the last few weeks.
And they're clearly down throughout the United States. Yeah. So we're not having as many deaths because we don't have as many positive patients. So that's a good thing. Do we think therapy has improved in the last few months? Because my sense is that therapy's been, there's some tweaks here and there, but we've kind of got the same plan we had even back in November, December. So I can't tell you that we have really brand new ideas that we're working.
Yeah, I think therapy has plateaued. I think it's more really a function of the vaccination, especially those most vulnerable groups. Early on in the vaccination rollout.
Yeah, and another point is if you start getting sick, get tested, because the monoclonal antibodies do work, even against the variants, because great evidence showing the Regeneron worked well against the South African variant.
Yeah, we stopped using, and the FDA actually pulled the emergency use authorization for that first Eli Lilly monoclonal antibody, but they do have a combination monoclonal antibody you can use. We still are using Regeneron, and we just looked at this the other day. Our results from patients that have gotten the Eli Lilly any of the monoclonal antibodies, Eli Lilly or the Regeneron products, is consistent with their trial data showing that those patients that are at highest risk of severe disease and hospitalization, you can reduce their hospitalization significantly. We've only had 3% of the people that have gotten those monoclonal antibody products either come to the emergency department for a follow-up or be hospitalized, so significantly reducing their chance of progressing.
And remind our audience, what do you have to have, or what are the inclusion criteria for being able to get the Regeneron monoclonal antibodies?
Yeah, so the monoclonal antibodies, it's patients who are over 12 years old or 40 kilograms. It is a positive test really within 7 days, because getting this treatment earlier is much better than getting it later, because we want to give it to you in that viral phase when you're having active viral replication. That is really the main inclusion criteria. If you had the vaccination, you can still get the monoclonal antibody as long as it is within 14 days after your first dose. Anything on that 15th day or not after your first dose, you are not eligible. But really, even with one dose of the vaccine and you're only 2 weeks out from that dose, you're still eligible to get it.
And the Regeneron antibody product, guys, in order to get it, is it just if I have a positive test, do I have to really be more of a certain age or have other chronic health problems?
Yeah, we certainly are screening for certain other criteria. Age is one of them, other comorbidities as well. We have loosened those restrictions a little bit because we do have a lot of stock and supply available. We are able to give it both in our emergency department and our infusion center. So we do have a system in place, and we have people who are actively calling our recent positives if they otherwise meet criteria to talk with them and discuss with them about getting the product.
So don't hesitate, and you don't even have to be a patient of our health system as we were originally. The monoclonal antibodies do work, and we don't want you getting sick out there. And if you haven't been vaccinated and you get sick, get tested, because those antibodies do work.
Speaking of testing, can you address concerns that current testing does not detect the new variants as effectively?
Well, I'm not sure. I haven't heard that, guys. Is that anybody else?
Yeah. No. So initially in the UK, they had what they call was an S dropout, and what that means is in the PCR test there are typically 2 targets that we look for on the RNA to detect the virus itself. One of those targets is in the S gene, or the spike gene. What they saw in the UK was that S gene target would drop out, so they wouldn't be able to detect it as much. That was also one of the reasons, or one of the ways they first identified the UK variant in Colorado. An astute group there identified this S gene target dropout. We aren't having that issue here with our with our PCR targets at this point in time. I do talk with Dr. Leisman on a regular basis. We are aware, but again, probably what's going on right now is a majority of any of the cases are probably going to be the B117, but we aren't necessarily seeing that. But that was an initial way that they were being able to detect the UK variant in particular.
What treatments are promising when it comes to moderate to severe COVID? Are you still promoting every form of oxygen over a vent?
Yeah, that's a good question. We kind of hit on it a while ago. We just said there aren't really new treatments for moderate to severe COVID. I mean, tocilizumab, we use some and a few other things. We're not using ivermectin, though.
No ivermectin.
And oxygen is always preferred in any form besides a ventilator. We try to avoid the ventilator because, in fact, ventilators themselves can cause lung injury. We know that from all of our patients in the ICU. And so we prefer not to use the ventilators. For a while, we were trying to go to ventilation early because we thought that could help stop disease transmission that we've learned along the way that really it's better to try and avoid the ventilator as much as possible.
Yeah, I mean, the treatment modalities right now, if you're an outpatient, there is nothing but the monoclonal antibodies. And if you're at high risk of getting hospitalized and severe disease, you should definitely get that monoclonal antibody, especially 7 days from symptom onset. Within that time, as you come to the hospital, the treatment continues to be Remdesivir. It continues to be dexamethasone if you meet certain criteria like increased oxygen need, and then of course anticoagulation, blood thinning to help prevent or treat any blood clots that may occur, because we know blood clotting issues are a significant issue with anybody that gets COVID-19. And then occasionally there's a smattering of this other drug called tocilizumab, which is basically a drug that helps affect that immune or inflammatory pathway cascade, but that is really only used in severe and critical illness in the ICU. So just as you said, the treatment for that has plateaued. Now there are other things that are being looked at, especially oral antiviral therapies. Those are in early trials. Some of them seem promising, also some inhaled things, but we are still waiting for the full evidence on those.
I think that would be really great if we could just have that influenza pill. We need Tamiflu for for these folks.
Is it safe for my husband to go to a restaurant? He's vaccinated, but he's in stage 5 kidney failure and is currently on the transplant list here at KU Health System. Is it too risky?
I guess we really have to answer this question, Lance. What do you think?
Yeah, I mean, I don't think we're at the point where, a restaurant is somewhere where people are eating, so they're going to be unmasked. You don't know who's vaccinated, who's not in that area, and there's going to be probably a large proportion of people in a small enclosed area. So I would say that would be a higher risk environment, especially for someone who is in a higher risk category. Mm-hmm. So I would say that it is an increased risk and something to avoid. There's options of eating outside, patios, things like that I would recommend before doing something like that.
Yeah, I'm kind of where you are. And Hawkeye, as well, when you have chronic kidney failure, your response to the vaccine may not be as good. Mm-hmm.
Yeah, and that is one of the questions being looked at to any of that, whether it's chronic kidney disease, chronic liver disease. We know that people with chronic liver disease sometimes don't even react to some of the vaccines we give them to. So, but again, I think it is higher risk sitting indoors at a restaurant at this point in time. I know I still don't feel comfortable doing that. But if you can't, it is less risky because you have been fully vaccinated. It would be less risky if you go outdoors, just as Lance said. But you just have to weigh those risks and benefits, and please discuss that with your medical team as well.
And just to say, I think it's really important for us to take note. You're on a transplant list and you're hoping to be transplanted, that call could come anytime. I would not take a risk. And so my answer is, oh, heck no, I would not go to the restaurant if I'm on a transplant waiting list, especially when I know that vaccines in patients with chronic diseases like transplant patients who tend to be even more immunosuppressed, those patients are at higher risk for bad outcomes from COVID-19 and are at risk for the vaccines not being as effective. So I would not go to that restaurant.
And even if you have active infection, they probably will not transplant you.
Oh, you're not going to get transplanted with that.
Or if they find out later, as has happened with some surgeries, because some surgeries are emergent, we understand that if they take an admission screen, they don't have time to wait for it, you're still going to surgery. But even though you have that infection, you then are at higher risk of adverse outcomes for having COVID-19.
Yeah, but I think in a transplant patient, or before the transplant, you're going to get tested. If you're tested positive, I don't think we're going to transplant you. I don't know. We'll double check that.
Do we know where most of the COVID cases in our area are coming from when they come from other counties?
Well, I think we can see that on the Kansas by county map of where they're occurring. I don't think with our inpatients we drill down that far to keep that in mind.
And I'm not sure that's an answerable question, really, because I think it's hard to know. If the question is, are other counties getting disease into Johnson, Wyandotte, Jackson County? I don't think we have a way to know. There's just so much widespread community spread. I think it's impossible to know. If the question is, where are our patients? What counties are our patients coming from? There, a lot of it's population density. So Johnson and Wyandotte we get a lot of counties, and then it just kind of goes down from there because the counties tend to be less dense. So you just won't have the same numbers.
Yeah, and Dr. Weil had talked about yesterday. I think there were 2 patients transferred in recently from other places, which hadn't happened in months for getting COVID transfers in. So I don't know that I don't know what those counties were, but. Again, I think we were seeing really no transfers in for COVID itself, and then just recently.
Well, for a while, because back in May, we had all sorts of.
Correct.
We had them when people were sicker and things were really.
They were coming from other states at that point.
Yeah.
Have you heard of any psychological effects on people from the vaccine?
Yeah, the psychological effect I had was, man, I am free at last.
Yeah, I mean, a sense of agency, a sense of freedom, but nothing negative.
Detrimental. No, I've not heard anything detrimental to you.
No, other than, anxiety has been pretty well publicized now. And I think it's anxiety over that blood clot issue, specifically maybe with the Janssen vaccine. But again, we know that you have a 1 in 5 people who get COVID have blood clots versus 1 in a million who get that Janssen or Johnson & Johnson vaccine. So I think it's really just the anxiety. But as far as specific diagnosis after getting the vaccine, I haven't heard of any.
Actually, what I've seen is that anxiety overall has dropped for people who are vaccinated because they feel better. They can get back out and do things, and they don't have that sense of impending doom because they're so afraid about taking the mask off and having COVID-19. And I think one of the things we've even said to some patients of mine who I follow who, they've been a little reluctant, they've been vaccinated, and they're still so scared to get back out in society, but they're also ending up having problems with depression. So the better thing to do is really to get vaccinated, start getting back out in society. Maybe you take baby steps to help yourself feel safe, but you got to get back out there, and the best way to get out there and feel safe is to be vaccinated.
All right, last question.
Yeah.
How will we know when the pandemic is officially over? Will some government agency make the announcement, or is there some number threshold that must be met?
Yeah, we've had this question. I think I had this the last time I was on too. This is a hot topic for a lot of folks.
Is this your question?
Did you turn that in?
And I think we have to look at this. I mean, I've said this before. It's called a pandemic because it affects the entire globe, and it bears repeating because we're talking today about our numbers, and 4,000 people are dying every day in India due to COVID. So I think it's we're going to be impacted by what's happening all over the world. And, this will be incremental steps. I think it's not going to be like a light switch turning on and off. We're going to see transitions into social and economic normalcy. That could include, it could be specific to a region, a state, or hopefully, in our case, a nation, of getting to a point of either herd immunity or something else that helps us tolerate some sort of normalcy. So I think that we can get there, but also, thinking about the entire world, there's, the continent of Africa, I think they have way less vaccination rates than we do right now, right? So it's like, we are all in this together, just like we were before when it started. So, I think if you're looking at state by state or national changes, we'll see that. We've already seen that in some of our governmental restrictions being lifted. And then, you have to anticipate that there may be outbreaks that we have to manage, as they come with different sort of masking restrictions, lockdowns, things that happen. So,
yeah. Yeah, I think that's right. What do you think?
I mean, I think you have to understand, how do you define the end of the pandemic?
Yeah.
Is it lifting of mask mandates and lifting of capacity restrictions? I don't think that's the answer. Is it a reduction in the workforce that is still sick at home? Is it the reduction in the shortages that we're seeing now? Is it return of the global economy? Is it reduction in hospitalizations and deaths in our country or worldwide. I think it just depends how are you going to define the end of the pandemic, because right now it looks like the virus will continue to circulate for quite some time. Again, the way out of that and to get that to speed up is going to be vaccinating as many people as possible, as quick as possible. But I think you have to understand and set parameters like how are you defining end of the pandemic.
Yeah, and I think when we're talking about herd immunity, that doesn't always mean eradication. Those are probably two different things that we need to focus on. And looking at, I think I've seen some scientists talk about, what we tolerate with flu. Is that something that if we get to the rates of what we tolerate with flu, is that a time when we can kind of just go back to what's normal for us? However, we've seen with this last flu season that maybe our tolerance for flu is way decreased than it has been ever before, because we know that if we do some of these things, we can stop the 100 deaths per day that we usually see.
Yeah, I think this is a great question, but I think the real thing is you have to say, what's a pandemic? Mm-hmm. And is influenza a pandemic? Because a lot of people have it. Nah, not really. I think what we can say is that COVID-19 is here probably for a long time. Mm-hmm. And the only way to ever really get rid of it is to have everybody get vaccinated across the world, and then keep getting people vaccinated even when they're very young. And I think that will. But can we end what we have come to understand to be the pandemic? Because the pandemic is different, because it involves lockdowns, it involves masking, it involves changing our way of life. Mm-hmm. Is there a foreseeable end of that? I'm reminded of that childhood song, inch by inch, row by row, gonna make that garden grow. Because inch by inch, we can do things to help the pandemic, but it will take all of us marching in that same direction and working together to get that done. And we can get that done. And the ways we can get that done include following the rules of infection control, which continue to travel with you wherever you go, becoming vaccinated, and trying to talk with your friends and family to help them understand the importance of vaccination, not only for themselves, but for the people they care about. Vaccines are safe. And at some point, you have to ask yourself, at what price sanity? At what point do I say, I am not going to continue to believe in conspiracy theories and paranoia and listening to people who really don't know what they're talking about, as opposed to science? We can say that, the science is wrong and this is wrong, and then we've said, we're building the airplane while we fly it. But the reality is the science around vaccination is not new. The science around messenger RNA vaccines is not new. The science around the idea that we can prevent disease transmission through vaccination, like, for example, the polio vaccine, is not new. What concerns me the most is that when people choose to sacrifice their own sanity and believe in paranoia and to believe in these apocryphal tales of terrible things that are just made up, you have to ask yourself, at what price have we given up our sanity, as opposed to just simply taking a simple step that we've been taking for many years now. And we take it every year when our children get vaccinated against polio, when we do the MMWR and our MMR, and here we are with something that can help save us all, and we choose to make a sacrifice of our own sanity, and we start choosing to believe in falsehoods as opposed to the science of vaccination. Vaccines are safe, and COVID vaccines like Moderna and Pfizer are near miracles for us because they are so safe and they're so efficacious. And if you want to bring an end to the pandemic, you have to bring an end to the paranoia. Hey, on Monday, we have a pretty good program. We're going to have a treat. We'll have 2 scout leaders from Troop 921, the St. Elizabeth Parish in Waldo, on with their troop leader. They did a special video project about COVID-19 safety to earn a badge. We're going to show you that video, but before, Lance, final thoughts today?
Get your vaccine. Mm-hmm. The virus, when it runs out of people to infect, that's when we get to a better spot. So,
yeah, ever increasing evidence that the vaccines do protect you, especially against these circulating variants. We know there was a lot of concern from the questions today. The vaccines do provide good immunity to these circulating variants. So please, everybody, get out and continue to get vaccinated.
All right. We're going to show a video now that's about what these Scout members did.